Good afternoon, everybody. I'm Steve DeMello, Director of Healthcare here at CITRIS. I'd like to welcome everybody who's here in the auditorium today, plus our web viewers. A few announcements before we get going. First is a reminder that our Eye for Energy talks, which run parallel to this series, continue this Friday with Chris Jones on how to measure your carbon footprint. Also a reminder to folks about the Big Ideas competition. Informational flyers are in the back of the room. This year we have a total of about $45,000 to award for outstanding student proposals, and we're in the midst of the information meetings and support if you are interested in participating. It's my great pleasure today to introduce our speaker, Dr. Jeff Newman. I think there's a perception that in medical and health services research that most of the work is being done at the university level and in academic centers, when in fact an increasing amount of really terrific work is also happening at the community level, particularly community health systems. And we're fortunate in Northern California that Sutter Health is really a national example of blending both clinical care and clinical research, and Jeff has been a major portion of building those programs at Sutter Health. Jeff is the director of the Sutter Health Institute for Research and Education, where he studies clinical information systems and their alignment with medical and nursing workflows. He's also an adjunct professor at the Institute of Health and Aging at UC San Francisco. He received his MD at Tufts University, his MPH in epidemiology right here at Berkeley. His topic today is my love-hate relationship with clinical information technology. And please join me in welcoming Dr. Jeff Newman.
Thank you very much, Steve, for inviting me here today and for that nice introduction. As you can tell from my title, I'm going to be presenting my personal rather than organizational views on this topic today. If I can get the technology to work here. Shire, as Steve mentioned, does health services research, and we have a major focus on clinical IT, but we also work in other areas, as you can see here. I distributed a paper that was the inspiration for my title and focus today. I don't know whether you all saw it. It's from the British Journal of Quality and Safety. But the title of that article is Problems and Promises of Innovation, Why Healthcare Needs to Rethink Its Love-Hate Relationship with the New. So that's where the love-hate idea came from. And I'm going to be focusing on our studies of clinical information technology at Sutter. In the article, they had three main points that in the dissemination of clinical IT, and probably in other areas of IT as well, but specifically clinical settings, there's a lot of uptake of the dubious, rejection of the good. The uptake of the dubious coming from magical thinking, a bias towards action and what's new, and the rejection of the good frequently coming from financial incentives, where business needs are not aligned with what is best for patient care or public health. Another major point or paradox they raised, the wisdom and failings of democracy. These are their words. The wisdom that social movements are what is most effective at spreading innovation, including technology, where the users are genuinely excited about it, rather than it coming from regulation or other approaches. But, of course, there are frequently conflicts between business agendas and clinical agendas, as we're all aware of. And then finally, that health systems like mine, and I'll be describing it, are never able to keep up because innovation is occurring too rapidly and our systems are so complicated, and there's just difficulty that I'll be describing. So the key points that I'll be illustrating are that the drivers of innovation are often not clinical, but economic, political, organizational. That the considerations for effective planning of dissemination of clinical technology is, one, good studies that they work in R&D and early adoption settings. Extremely important is the site readiness for these technologies. That there's support of the training, education, and workflow alignment that is necessary. And then finally, with implementation, rollout, that there's measurement and monitoring, looking for both negative, unanticipated consequences and also benefits, unexpected benefits. So I'll introduce Sutter Health, just elaborate on the point Steve made about how big it is and our activity in the area of these clinical information technologies, the challenges that we've experienced, and then I'm very much looking to a dialogue with you, with your ideas and suggestions. So, starting with an ad for Sutter Health, it's approximately the same as Kaiser in Northern California. You may not be aware of that because a lot of Sutter is the particular affiliates, which I'll be mentioning, rather than the system. We are not as organized and integrated as Sutter. We're still working on the integration. In terms of the size, you can see 50,000 employees, $9 billion in revenues, $10 billion in assets. Here's just a picture of Northern California, and the white dots are hospitals, the red dots are our medical groups. And we've now developed 5 regions, so I'll just describe them. You may recognize some of these individual hospitals and not connect them with the Sutter system. For example, Outbate Summit here in Oakland and Berkeley, and they have a research institute there. Shire is the health services research for the system, but we have local research institutes. This one focused on clinical research. In the Peninsula region, we have Mills Peninsula Health Services, a big hospital, and Palo Alto Medical Foundation, a powerhouse medical group. It has its own research institute and very elite health services research program, nationally recognized. In Sacramento, there's a number of affiliates, and there's a research institute in there. In San Francisco, California Pacific Medical Center with 4 different campuses, and they have a very prominent research institute as well there. Now, you all are probably familiar with this dogma that in trying to understand the benefits of technology, that it's not just the technology itself, it's how it's aligned with the people using that technology, the organizational setting, and the particular tasks that it's addressing. Another theory to explain what's going on at Sutter, which I'm about to describe, is this idea of diffusion of innovations. That it starts with innovators. Many of you will probably be very active in that space in your career. We hope you'll do some work with us. But it's very challenging for busy clinicians taking care of patients to deal with IT at that level when the bugs haven't been worked out yet. Sutter has jumped in fairly early in some of these that I'll describe, and have had to deal with some developmental issues with the technology, as well as adapting them to our workflows. And then, of course, there is the majority of eventual users or potential users, and then the resistors or laggards. Okay, now this is the first of the three technologies I'll be describing at Sutter. So that top picture, this is the electronic intensive care unit. So off-site, the bottom picture is the EICU, where the physician and nurses is monitoring care in a number of our affiliate ICUs. The reason for that is that there are good studies, and this is certainly not surprising to me. When I was a trainee taking care of intensive care unit patients, I would have loved if some expert was monitoring what was going on and available to help. And that's still the case now, that there are not enough intensivists to staff all of the intensive care units in local hospitals. So that's the idea, that the EICU provides the extra level of monitoring. So we have two hubs. That picture is the one in Sacramento. And we do have some evidence the use of the EICU has improved mortality and morbidity among our ICU patients, shortening length of stay, and improved the work experience. So, of course, in this picture, everybody's got a smiley face. They're helping their colleagues at the local ICU. And the top is what the patient sees, the camera that's looking at them in their hospital bed. And that they can zoom in and they can look what's going on. They can talk to patients. And it can be intrusive, as you can imagine. Okay, so our evaluation of looking at it is that the context of the EICU is explains some of the difficulties we've had being an early adopter. On the right, you have on the top, that's the nurse in the EICU monitoring the data from the patients at the affiliate ICU. At the bottom represents the physician in the EICU. On the left, you have in the ICU where the patient is, where the care is actually occurring. And at the bottom, the complex group of clinicians who are actually providing the care. So they may, in some cases, be these fully trained intensive care specialists, where it's not so clear the need for EICU, but there also is a variety of other physicians, like hospitalists, who are taking care of everybody in the hospital, or attending physicians who may be primary care docs, but they choose to follow their patients. This is decreasing. It's more and more the hospital care is by hospitalists. But there's still some physicians who just come into the hospital once in a while, and they just have ICU patients once in a while. And they, probably similar to my recollection when I was working in the hospital as a trainee, where there's great advantage in having that specialist backup at the in the EICU. Now, part of the way this works is not the technology, it's the clinical issue, is the clinician gets to decide how they use the EICU. So they can choose to delegate all the care to the EICU, or they can choose not to delegate it, and if the EICU notices a problem, they contact the on-site physician, or maybe not on-site, and give them the information, and they decide what they want to do. So in our evaluation, what we found, not surprisingly, is that this works best when the local physicians delegate to the EICU so that they can take care of issues as they arise. But actually, there's still a very large number of physicians, for a number of reasons, who don't want to delegate that. So we have EICU throughout Sutter in our hospitals, but we don't have full utilization of that. And that, I believe, explains the mixed picture that we've had in our evaluation. While overall there have been some benefits, it varies among the different hospitals. And one of the factors explaining that variation is whether the physicians are really on board with the EICU. And the nurses tend to be more committed and invested in this than the physicians. They're just, professional and ego and political issues why there's variable commitment of this by the physicians. So what we recommended to improve the benefits of EICU is to get the physicians on board. And also, when this came out, because we were an early adopter, the information systems were primitive. The developers of EICU, who were intensivists and technologists, they could make these primitive systems hum. But when you're asking other physicians who are not invested in this, and it's a lot of work, and there are difficulties in using the information, and it's redundant with the work they have to do, paper or electronic, it's very hard for them to commit that effort. So this is what we recommend, and we're still really in the process of doing this. The one hospital, I'll be talking about electronic medical records in a moment, but the one hospital that has electronic medical records and the EICU and the local ICU are using the same electronic medical record, this works much better. So this is an issue of juggling technologies in the hospital, taking care of patients, and a lot of workflow alignment issues. This is the second technology that we have carried out extensive evaluation. So this is EMAP, the Electronic Medication Administration Program. It has to do with barcoding to prevent errors, like the wrong patient getting the medicine, or the patient getting the wrong medicine, or the wrong dose, or the wrong time, whatever. Anything that can go wrong in a hospital setting, unfortunately, it does go wrong. And we try and minimize that, and this technology is specifically focused on trying to prevent those medication errors. So the way it works, the picture demonstrates, I'm not sure how clear that is to you, but the nurse on the right has a scanner, and he's scanning the barcode on that patient to make sure the medicine he's about to administer is right, and it's the right dose, etc. So before I present our more critical evaluation, this is the way it's presented in terms of the rosy scenario that $50 million investment, 16 million medications administered, 170,000 errors prevented, and 15,000 potential adverse effects on patients. This is a significant risk of patient harm. And actually, those estimates are based on our study, which I will describe here. So, again, this is our way of looking at critically at what's going on with these information technology, the human factors as well as the technology. So the physician writes the prescription and it gets entered into the pharmacy information system. then the nurses come around. And by the way, nurses, the situation of nurses in hospitals is very challenging. You may read about that in the news. But they spend more than half of their time doing paperwork. And then they have to come around and give these medicines. And, obviously patients in the hospital are getting a lot of different medicines. And so there's a lot of opportunity for errors to occur. So the nurse scans the patient and the medication, which has a barcode also. And then if there's a problem, there's a warning that pops up. That yellow unhappy face there. And the nurse has to decide at that point to not give the medicine at the bottom on the right and prevent the error, or make a decision that the warning is not serious enough and make the judgment to go ahead and give the medicine, and that's the possibility of an error. Now, does anyone want to, just from this very limited information that I've given, anybody want to make a guess what's the underlying problem here? Please.
60% warnings.
Right, exactly. It's too much noise. Nurses, I said, as I mentioned, they're really busy to begin with. And here they're getting an information system that, of course, we all agree we want to prevent these errors, but it's too much. It's just noise. So we evaluated what was going on. And what we found was that we're very happy about, and that led to that information that I presented earlier about the benefit, is that 1% of the time when the patient was going to give a medicine, there would have been a significant error, but it was prevented because the nurse didn't give the medicine because of that warning. 2% of the time, despite the warning, the patient was given the medicine, and so we're calling that an observed error. Now, one of the hypotheses we had was that these prevented errors. Oh, by the way, so as your colleague mentioned here, there's noise. What about all those others? If only 1% of them were prevented errors and 2 were errors that occurred despite the warning, what about all that other 40%? It was noise. That was noise. And the reason was because the information, when you get it out of the box, is slanted towards extreme conservatism. So anything that could be a mistake generates a warning. And for example, the medicine is slightly too early or slightly too late. They had a fairly tight window around the timing of the medicine. Well, as I mentioned, these nurses are very busy. And if the doctors are writing a whole hodgepodge of different schedules for their medications, the nurses can't be running around, oh, now I have to go give this patient the medicine, and now I have to go this. They couldn't do their work, so they have to compromise. So it's actually quite reasonable that they were overriding a lot of these warnings because they were noise. They understood that. But the problem was that there were more errors slipping through despite the warnings than there were that we actually prevented the errors. So what did we do about that? To address this alert fatigue, we asked the physicians to simplify the orders. Physicians have their own way of doing things, and it just makes it extremely difficult for the nurses to deal with that. Now with hospitals, it's a smaller number of physicians. That's getting better. Then we had the pharmacists with the information systems reduce the sensitivity of these settings for the time range, give a longer range when that's appropriate and reasonable. And then another factor leading to all the noise was that people report all kinds of allergies, and whatever gets reported goes into this information system. Many of them are very mild or even unclear whether they actually have those allergies, but it all went into the information system. And then even more so, the drug interactions is very many medications have multiple minor drug interactions, and it's really only the serious ones that we have to mainly work on. So that's what we recommended, is that these alerts be filtered, focusing on high-impact errors like the wrong patient, the wrong medicine, or high-risk drugs such as warfarin, a blood thinner. Actually, there's a new medication, much safer, that has replaced warfarin, and then insulin controlling blood sugar or sometimes knocking it too low. So there's very serious adverse reactions. So if we focus on that, we'll reduce the noise that you pointed out as the obvious error with this problem with this system. Any other comments or questions about that? Okay, then I'll move on to the third information technology, and this, of course, is the big one. And I'm not going to be, you see here in just our promotional materials that Sutter Health is considered a best practice for EHR, that all of our medical groups are live. We're taking care of 1 million patients in those medical groups that have the electronic medical record. A quarter of them overall are accessing their medical records online. Can I just have a very brief survey? How many of you have access to your medical records online? If you could raise your hand. Okay, it's still a minority. Some of you may be so healthy that you're not having too much interaction, but that's the way the world is going. More patient-centered. This certainly facilitates patients being involved with their care, simplifies making appointments, getting lab results, etc. In Palo Alto, we have state-of-the-art, the cutting edge of electronic medical records, as well as on the personal health record side. We're much slower in terms of our hospital implementation. We only have one of our hospitals, Mills Peninsula, which I mentioned earlier, relative to the EICU. And we're speeding up our implementation in the rest of the hospitals. And this has to do with very complex issues, workflow alignment, readiness, technology, etc. Now, what I'm going to present here is actually from a study at UCSF that I participated in a number of years ago. And again, you have that diffusion of innovation. For this study, we wanted to know how it was working for the electronic medical record users in small groups. And the first, and I think the most remarkable thing we found, this is about 10 years ago, it was very hard to find users of electronic medical records because there was a lot of resistance to it, and some of it appropriate because of this business of the challenges of early adoption. But even if they did purchase it, and in these small practices at that time, $20,000, $30,000 was a very big cost for them to swallow. But even those who took the plunge, most of them became so frustrated with it that they gave up. So when we got lists from these professional organizations of alleged users of electronic medical records, when we actually contacted them, they said, sorry, we gave up. We're not using it anymore. Then the ones we did find we found, and this was the major finding, is trying to describe the different types of users of electronic medical records. And we found many of them we called viewers that didn't really take advantage of a lot of the functionality of EHR. They would basically just look at lab results or whatever could be brought into their system, and they could just look at that. They might dictate records, and then they could just scan them in and then call back those. They weren't entering data. There wasn't discrete data that they could use. Then we had basic users, strivers who were really working very hard to make it work. And the problem was, to make it work, they have to put a lot of time into that. And these were busy clinicians who already, with their practice and their family and so on, they were already very busy, but they were really dedicated. And so the strivers were struggling to make it work. The arrivers were making it work. And then we had a small number of system changers. Now, at Sutter, we still have small practices. But what's going on now is, and another point I'd make about an improvement from the situation here was there wasn't good backup. The vendors of electronic medical records didn't really help the individual physicians who were struggling with that, or small practices. And also, there weren't a lot of IT support for that. Now it's much better. Vendors, well, first of all, they have better products now, and there is much more use of them in small groups, including at Sutter. But what's happened in big groups is it's done in a more organized way, and they do have the IT backup, and that explains why it's working at Palo Alto Medical Foundation, on the cutting edge, and the rest of our practices at Sutter. But the fact is, viewed critically, even in our medical groups where they're using Epic, which is considered the best brand of electronic medical record, many of them are not taking advantage of the full functionality. And we have more or less these same categories, where we have our super users and who would fall into that arriver category, and actually helping to change the system. So I think this relates to electronic health record, but also to these other technologies, these general comments. One is that, and this is true in our system, at Sutter, for example, but also I think in the public sector, that there should be better organization of the research and development, focused on the usefulness of these tools in the clinical settings. And for example, at Sutter, we have a dissemination plan which frequently we're trying to roll it out as quickly as possible. And sometimes problems are not really worked out at the first pilot facility that would make it much easier to roll it out well to the other affiliates. And then thinking about these different groups, innovation, and I'm sure you're going to be involved in that group and working with clinicians who are also innovating these and want to work together with you on these clinical information technologies. But from our system point of view, if they're too far out there, it's going to make it more difficult for the rest of the system. Sometimes it has to be softened to get the full dissemination. So I think there really needs to be thought through the R&D, the early implementation, and then the wide-scale dissemination. Early adopters, because many of them are not taking advantage of the full functionality, that there should be more education of the benefits, and of course simplifying so far as possible to achieve those benefits. And then we have to remove the barriers, of which there are still many. General recommendations, more involvement of clinical stakeholders, and I hope that those of you who are interested in clinical information technology, that we welcome you working with us if there are opportunities with our research institutes. There are a number of other options, but we're very interested in this work ourselves. Maximizing clinical decision support so that there's good information but not a lot of noise. That's constantly happening. Just recently, we have to address at Sutter this same issue cropping up again of the settings. We just erred on the settings were too sensitive, too much noise. The clinicians wanted to get rid of the whole system. So that's the hazard, dealing with humans and love-hate types of reactions to technology. Once you have clinicians very angry about a new technology, it's really hard to overcome that and get them on board. It's much better to anticipate these problems and have them on board with the process. More love, less hate. Communities of practice. Now, another thing I'd like to mention here, and if there is anyone in the audience who wants to drill down on this, but we want data. As researchers, we want to have good data. And I mentioned EPIC is considered by some to be the state of electronic medical records. It's the transaction system. It's set up very well to take care of a large number of individual patients, one at a time. However, the guts of EPIC is MUMPS, and it's a hierarchical data system. And when we want to have relational databases and registries, we are still, despite this gigantic investment, still having great difficulty in getting the data in a way that we can look at it population-wide. So I really don't understand the technical obstacles here, but that is a very big problem. Clearly, as a society, we know we want to look at what's going on at the population level, and there should be ways of overcoming this problem. As I say, some of you either now or may get the expertise to help with this. I think there are great opportunities in this area. And as you know, there's a lot of work going on now with health data exchanges. So sharing the data with multiple systems. And this problem arises there is that each system has a proprietary nature of its, the way their data is set up. And there are a lot of technical problems. And what you have is a lot of vendors who promise to build the interfaces to make this happen, but their interfaces are themselves proprietary. So it's unclear that some of these data exchanges that are being built are going to be able to connect with other exchanges to really make this eventually a national system. So this is a very big problem, and we are struggling with it. Okay, so my cartoon here to wrap up is this is my colleagues and I at Sutter sitting around with reviewing our data from our evaluating information technology, and we say we have lots of information technology, we just don't have any information. So, yes, please. Yes. I think you're giving one example of a problem that should be solvable if we would really make our best efforts. I mean, we can't even get the information in our own system very well. to track down other people who have had that condition. By the way, electronic medical records, they're really great at speeding up the process of treatments. So you can identify everybody who needs such and such diabetes treatment or immunization or pap smear or mammogram or whatever. But what happens if it gets programmed wrong? That gets speeded up. The errors get speeded up as well. So there's a lot of risk involved with this as well. So thank you for that particular question.
It was just an experience I went through, and it was very frustrating to her for a lot of years till they could really figure out what she had. And even the best neurologists and everybody were looking at, and finally somebody sent it down to the National Institute of Health, and luckily they were really good down there, and they figured out what she had, you know. But
was it a rare condition?
Yeah, it was moya.
Yeah. There's I just happened to read the New York Times magazine, and there was a case, they have a little medical column, and there was a patient with hiccups, and it went on for 2 days, and they couldn't figure it out, and finally they discovered that it was it was just a manifestation of a very serious problem, pulmonary embolus. But this is the power of eventually artificial intelligence and decision support if we would really get our act together. But clearly we're a long way from that at this point. Yes, please.
We had the same problems of communication between computers and exchanging data. And your question was how to improve this. Well, in the electrical and engineering departments, they set up standards to be used nationally by the whole industry. I think you'd want to set up a board in which certain standards were set up for transmission of information and how it would be done, and categorizing it, and so it's acceptable to the whole community. Otherwise, you're never going to get around it.
Right. I think that is the way to go. My understanding is it's not occurring as quickly as possible because of resistance. And there are business interests involved. But like in banks, they figured out how you can get money out of the machine, We should be able to, as you say, set up standards so we can share this information. If you can help figure that out, or your trainees, that would be great. I think this should be a national priority. As you say, there are a bunch of people working on it. But there's resistance to it, and it's not happening as fast as it should.
Also, we had a great problem between letting go of control, this is at a clinical laboratory level, to the whole operation of the hospital, because they didn't know what we were doing, and they didn't do what we wanted them to do. So, establishing a communication and letting go of control is a big deal.
Yes. Thank you.
Yes, sir.
Yeah, I'm interested in what methods are being used to harness the wasted talents and interests of early adopters who, as you said, experience a lot of frustration, but they're willing to undergo it. And one of the reasons some of them are willing is that they're interested in innovative IT. They want to participate. They want to help make it better. And they provide detailed reports of bugs, and they're willing to follow up. But in my experience, at least, as a frequent early adopter of electronic medical and other kinds of technologies, the input that early adopters give, the specific diagnostic input about what's going wrong and what could be made better, usually falls on deaf ears as far as they can tell. Maybe it's used, but they don't know. And it's very rare that if they submit a problem, that anybody takes ownership of that problem and gets back to them and continues the relationship with them until that problem is solved. I'm wondering if that's a phenomenon that you're aware of, and that the people who develop these systems are trying to deal with.
Let's just say I wish I was not as aware of it as I am. And if you find this reassuring, we have the same problem as a big customer. that you're describing as, an innovator. And this is just a major problem because the business interests are not necessarily aligned with improving it from a quality point of view, which is what we want. Thank you. And keep it up. And, the ideal thing is you figure out how to make a system that really works. My understanding is one of the very best electronic medical records out there is a physician, IT person, and he was so unhappy with what was out there, he just made one himself, and now it is very widely distributed. It's just right for the small practice. It's very different from this very complex program we have for our huge system.
So we have time for one more question.
How do you guarantee the availability and the reliability of the electronic record system? Because, if all the medical records or the drugs schedules are all electronics, if the server goes down, then what happens?
Okay, well, that's a great question. That is one of the risks. We try, because it is so important, we try and have redundancies with backups and everything, but it does happen, and we just have to do the best we can. At Sutter, we have not had any breakdowns that lasted very long. So we've had that good fortune. I think the risk of what you're describing is greater in the small practice, where they don't have IT people available around the clock that can come and deal with that kind of thing. Thank you.
Other questions? Great. Jeff, thanks so much.
My pleasure. Thank you.